Good evening, everyone. Thank you for joining us. On behalf of Alpha Phi Alpha Fraternity Incorporated's General President, Brother Dr. Willis Lonzer III, I am Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. I am going to engage this conversation very delicately this evening, and the subject matter experts that we have assembled, four of Alpha Phi Alpha Surgeon General Initiative's Deputy Surgeon Generals, will be talking to you on just the facts. It is not our goal today to get into anything other than the actual words and legislative proposals that are a part of Project 2025. The opinions that you hear tonight are not going to be those of Alpha Phi Alpha Fraternity. Any opinions expressed are going to be held to a minimum, but will be the opinion of the speakers, because we really just want to present information to you so that you can have that under advisement as you make up your own mind about whether this path is something that you find desirable. So to that end, allow me to introduce four of our brothers, Deputy Surgeon General, who will be joining us this evening. Brother Dr. Ron Bailey is the Kathleen and John Bricker Chair, Professor and Head of the Department of Psychiatry at LSU Health Sciences Center. He is also the Chairman of the Board of Trustees of the Cobb Research Institute and famously the past President of the National Medical Association. We love having him as our Deputy Surgeon General for Mental Health. Good evening, Brother Bailey.
Good evening.
Next up is Alpha's Deputy Surgeon General for Healthcare Disparities, Brother Dr. Robert Carter. Brother Dr. Carter is a doctorate and a full professor in the Department of Emergency Medicine at the University of Texas Health in San Antonio. He is also a colonel of medical services in the U.S. Army. He is also an elected fellow of the American College of Epidemiology and the American College of Sports Medicine. Of course, all of us are life members of Alpha Phi Alpha Fraternity. Good evening, Brother Dr. Carter. Third up is Alpha Phi Alpha's Deputy Surgeon General for Family Health. Brother Dr. Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha, and he's currently active in Alpha Eta Lambda chapter, where he practices at the Houston Methodist Hospital as the Associate Division Head of Hospital. You got a lot going on here. As the Associate Division Head of Hospital Medicine, and he's also the Director of Clinical Research in the Division of Hospital Medicine. Brother Dr. Narcisse is board certified in internal medicine and geriatric medicine, and he is a fellow of the American College of Physicians and of the Society of Hospital Medicine. Last but certainly not least is our Deputy Surgeon General for Dental Health. Brother Dr. Langston Smith received his DMD degree from the University of Kentucky in 1979. He joined the U.S. Navy actually after dental school and served 30 years on active duty. Following his retirement from the Navy, he served as associate professor and chair of the endodontics department of Howard University College of Dentistry for 12 years before retiring in 2019. And I will never let this brother go without pointing out that every single year he could be the Alpha Man of the Year, but he has been the Alpha Man of the Year in 4 chapters and the Eastern Region Alpha Man of Merit. Thank you, brothers. These 4 men represent a subject matter expertise that is very well positioned for the discussion of the hour. And let's just jump right into it. What we're going to be doing this evening is to take 10 points. This document is 920 some odd pages, but the health section is over 50 plus pages. So there's way too much for us to get into in the course of 1 hour. However, instead of stretching this conversation out over multiple weeks, we simply are going to go through talking points that we believe that you should know, that you would want to know. And as such, we want you to be informed. If you have specific questions, please put them in the comments and we will answer them when the time for that appears. But in the meantime, the goal of this is not at all to politicize this conversation, but just to present the facts. So with that being said, welcome. Topic number 1. Let's discuss what is described in the document as the fundamental right to life. This is actually located under the document's goal number 1, protecting life, consciousness, and bodily integrity. I'm going to read the exact language from the document. The Secretary of Health and Human Services should pursue a robust agenda to protect the fundamental right to life, to protect consciousness rights, and uphold bodily integrity that is rooted in biologic realities, not ideology. From the moment of conception, every human being possesses inherent dignity and worth, and our humanity does not depend on our age, state of development, race, or abilities. The Secretary must ensure that all health and human service programs and activities are rooted in a deep respect for innocent human life from day one until natural death. What follows then are two statements that are topics for discussion. Number one, abortion is not healthcare. Number two, euthanasia is not healthcare. Let me just stop right there and let me toss it to the group because there are a couple of points. Can you just elaborate or clarify what it is you're hearing in that declaration of a fundamental right to life? Any of you gentlemen, go ahead and jump in if you want to comment on that particular issue. I'm waiting.
Okay, I'll jump in there. So from reviewing the document, what I see is that the the role of government in protecting life. So the proposal, as you described, calls for the Secretary of Health and Human Service to ensure that all programs and activities under their jurisdiction is rooted in, as they call, deep respect for life. And so what this really gets into is revisiting and potentially overturning policies from the current administration, according to Project 2025, which have expanded access to abortion and weakened protections for the unborn. So the proposal suggests that federal programs should not be used to subsidize or support procedures like abortion and euthanasia, arguing that this could violate the principles of respecting life. And so the project also, again, advocates in this light for states to have greater roles in regulating medical professions, particularly in areas related to the protection of life, and again, ensuring that states enact laws that restrict or ban abortion and euthanasia within their borders. So the proposal suggests, Project 2025, that it empowers to make the decisions of values and beliefs of their residents basically to states as opposed to federal mandates. They may contradict with local moral and ethical standards. So I think it's that's another aspect of it, is that you could end up with a variety of different types of situations across the states, as opposed to more of a unified federal
Okay.
policy.
I
So
would
go ahead, Brother Smith.
I when I read that abortion is not a health issue, I'm concerned because when we look at the well-being of a mother who's pregnant, that is a very high-risk pregnancy, and that pregnancy might cause her death, and also the death of the unborn. Is that not health? Are we not concerned in respecting the health of that mother? So I look at that with a lot of concern and fear when we say it's not a health issue. In my perspective, it is indeed a health issue.
So, at the risk of, and I don't mean this as a bad pun, but splitting the baby here, what is not being offered in this declaration is any degree of nuance. I think over my career, I delivered at least 50 babies, probably more. And it is just factually incorrect to say that an inevitable or an incomplete abortion that requires and first of all, to the people in the audience, in healthcare, the terms miscarriage and abortion are used interchangeably. And when the layperson hears abortion, in many instances, we may be describing something that medically is known as a miscarriage. So the scenarios that are not being addressed here is if the assertion is being made that abortion is never healthcare, then that speaks against the clinical scenarios in which patients have a retained product of conception, a deceased fetus that is inside of them that they will not theoretically pass before it becomes infected, before they bleed out, and those actions by themselves can put the mother's life at risk. What this statement does is that even in those examples, there is no consideration for a therapeutic abortion. It's called a DNC, a dilatation curettage, that allows evacuation of the deceased fetal products. Okay, so that is where the failure of any nuance, the failure of any consideration of the life of the mother really comes into play. We bring that up simply so that you understand that this statement creates a value judgment that even in the cases of the life of the mother, the value judgment of protecting any fetus, any embryo is being placed as a higher priority than the existing life of the mother. Does anybody on the panel want to either take issue with that or elaborate on that point?
I want to speak to some mental health consequences, but if Brother Narcisse wants to go first, I'll defer.
Go for it.
Yeah, clearly. This has been a challenge, I think, in American medicine, the entirety of my now, 35, 40-year career. I think Brother Dr. Sterling's comment is correct. It requires nuance, and that's what physicians do. We look at a variety of variables in each individual case, and they aren't all exactly the same, which is why this is such a remarkably difficult, if not frankly impossible issue, I think, to optimally legislate, because legislation very often occurs from afar or without, I think, the capacity to consider the multitude of, I think, other variables that come into play, i.e. the reason for nuance. That being said, I'd also add, as a, again, long-term psychiatrist, it's just very, very clear that there are the astronomically substantive adverse consequences psychiatrically, psychologically, in the mental health sphere of the entire issue of pregnancy and risk of losing such, with the miscarriage, abortion, or the like, D&C. Throughout my career, similar to yours, Jeff, I've seen any number of settings where all issues are in play. They're remarkably difficult and challenging for people, young women, and families that they're often involved. And it requires really a tremendous degree, I think, of reconsideration in the midst of, I think, processes that challenge them, I think, emotionally. I would disagree that this is something you can legislate, because the mental health consequences can be too adverse. You can't force these concerns without leading to psychological difficulty.
So let me share some factual information for the audience here, just so you know where the medical standard is. The assertions that are being made want to respect and protect life and consciousness in this particular example. It's important to know where the standard is medically. And according to the National Institutes of Health, NIH, a fetus actually becomes conscious at about 30 to 35 weeks after conception. And the way in which we know that is that brain wave signals are traced and read at various stages of development of the fetus. And you can actually tell based on the amount of activity through those scans that correlates with certain types of readings that we get on these EEGs. And the medical community has actually concluded that, believe it or not, a fetus becomes conscious only after about 30 or 35 weeks. That would be one way that the medical community might address an issue about, well, if you're trying to protect consciousness, what is a reasonable point in time at which that would occur? A second consideration in this is that, well, if you went to the other extreme, again, we're not getting into the debate about vitality, which is somewhere else down the road. At what point in time an embryo or fetus becomes viable outside of the mother? We know that that's months down the road. But at the other end of the spectrum, a human heart actually begins to beat around 22 to 23 days after fertilization, which is around the 6th week of gestation. So there is logic. I wanted to bring those to your attention because when you hear proposals that say that anything under 6 weeks is a permissible procedure, when you hear these concessions being made, but the point to be made there, it is very, very difficult to even detect a pregnancy before that same period of time. So the question now becomes, are you simply outlawing any procedures, any medical procedures, any abortions, practically speaking, or are you actually interested in some nuance at which you look at what the medical literature says based on when the human heart begins beating, based on when consciousness begins, or whether you're looking at viability of the fetus outside of the embryo? In this document, what appears to be the case is that abortion is not healthcare. There is a call for, at the moment of consciousness, at the moment of life, which is defined when the human heart begins, that's what's going to happen. So for those of you that care about these things, that worry about integrity or control of your own bodies, this is something about which you should be concerned. I'm just going to stop there and move on to the next topic unless anyone has any other points they want to get in. There is one other thing that I want to say, because I could have and should have said this at the very beginning of the conversation. It is okay, and it is actually important for you to understand what this document represents. It is a logical fruit from the tree of a certain philosophy, a conservative philosophy, that or Christian theology, that if you believe certain things based on your religious inclinations or your political ideology, that all these things thus follow. So in this particular example, this comment from the same section of this document is critically important. The Secretary must protect Americans' civil rights by ensuring that the Department of Health and Human Services programs and activities follow the letter and spirit of religious freedom and conscious protection laws. Okay, we need to be clear that this document is not just a bunch of ideas. This is actually the following of a certain religious and political ideology that are internally consistent in what they're recommending. Let me just move on to the next one. I think you'll find this one fascinating. States should be the primary regulators of the medical professions. That assertion is located on the document's number 2 goal, empowering patient choices and provider autonomy. I'm going to read some exact language from the document here and ask the panel to discuss. The federal government should not restrict providers' abilities to discharge their responsibilities or limit their ability to innovate through government pricing controls or irrational Medicare or Medicaid reimbursement schemes. So that seems to be internally contradictory. I'd like for one of you to clarify it if you could, because what they're saying here is that 50 different states can have 50 different means of regulating medical professionals. However, states' rights are now being substituted for the federal government and its agencies' ability to regulate how these types of procedures should be performed nationally. And there's logical consequences to that supposition. If you'd like to speak to it, feel free to. Otherwise, I'll be happy to embellish. And I'll throw this one out just to get the conversation started. There's an inference in this that states are free to criminalize physician activity in discharge of their responsibility if you take away federal protections. Anybody want to tackle that? States' rights versus federal oversight?
Well, Ron, I'll jump in and I'll be brief. I think that historically, this has not worked well in the field of mental health. Inconsistent care has been rampant in various states around the country, which is why the federal government often comes in and puts hospitals and states in these settings up under some degree, I think, of conservatorship. In fact, early in my career, I was a medical director of a place called Bryce State Hospital in Tuscaloosa, Alabama. It, years before, had been placed under federal government conservatorship, in part because of the quality of care had been so inferior there compared to many other places. Out of that, for example, we got those so-called treatment plans. So the federal government having an oversight, ensuring that there's a minimum level of standard of care in mental health, has been helpful over the course of the last 50 years at least in ensuring a basic modicum of safety and optimized care for those with brain type illnesses. This language would perhaps undermine that progress over the course of the last several decades.
So are you positing that that is something that should be protected on a federal level, or more importantly, without giving an opinion on it, are you making a statement that that is something that's being taken away in favor of individual states being allowed to substitute their judgment in that regard?
The latter. The reality is our history makes it very clear that at times, and I've worked in some states where this has been the case, as I just pointed out, some states have not adequately funded mental health concerns, have not provided adequate protections in those settings. And in my professional opinion, as a 34-year psychiatrist, that has put particular individuals at a great degree of risk. So the federal government's hand in ensuring that there's a minimum level of safety and basic psychiatric care in state hospitals around the country has been good for psychiatry.
But let me open this up to the panel. What's wrong with individual states having the ability to decide if they want to regulate physicians' activities across the board?
Yeah, I'll just make a comment from a physician perspective and a public health perspective. So when we look at, I think there's three aspects of this. Is that there's healthcare access potential disparities, increased legal conflicts, and moral and ethical dilemmas that providers could be placed in. And I'll just hit the first one. Decentralized regulation is something that, by having a federal entity, has provided some continuity, and at least it's not perfect, but it has um, allow for some consistency, and also federal funding to be applied where necessary to address some of these challenges, as well as putting providers in places where they may be look at rural versus urban by having some regulation over this. Rural areas, for example, may struggle to have certain types of providers, emergency services, cardiology, and so by having, whether it's Indian health services or other federal programs, is able to provide some support where you have limited natural infrastructure for shortages and inconsistent in state regulations. So I think there's value in having a conversation across both, but again, the impact is that patients that may be poor in rural areas could see reduced access to specialized care, cutting edge technologies again, and also you could see some differences as well, a greater extent in licensure and regulatory framework. And also, as I mentioned before, it could positions and other healthcare providers in an actual moral and ethical dilemma. And as you pointed out earlier, they could be criminalized. And they may be, if they, in particular now, folks are working, virtually, mental health and other areas, it could put them in a dilemma. For example, not knowing some of these individual differences across federal lines, and they could be criminalized and not being aware of all these nuanced differences at the state level.
The concern I have is in the way that we implement the care, for example, for seniors. So the Medicaid program is a state administered program, and that's one of the primary ways that nursing homes are funded in the United States. And so across the 50 states, there's a wide variance in how much funding states give to nursing homes. So in some states, the amount of money that's provided is really barely sufficient or insufficient to provide the care for seniors. So developing the same kinds of paradigms have an advantage in trying to be flexible, and that's a reasonable goal, but also without a federal standard of the types of care that needs to be provided, it could leave some states, particularly states that choose to provide less to individuals, particularly elderly individuals. In my example, they could be in a very, very difficult place, and there'll be wider variances of this than is currently the case, because the current piece does allow for the states to regulate their programs, but has minimum standards, and this type of language could potentially reduce or eliminate those standards.
I am in concurrence with the 3 or 4 statements that have already been made and the positions that have been presented thus far. But I would also add that when we have a group of legislators who have no medical intellectuality on understanding what the medical situations are and how to address those situations, then it opens the door for greater, loss of access to care, greater loss of the denial of services to people, especially as has been mentioned, in rural areas, poor areas, and so it's across the board. And we find that I have that difficulty with that, and I think that's what this would allow for, even more of that to a greater degree.
Is anybody obviously concerned that 50 different standards across 50 different states leads to an excess number of deaths that would otherwise occur with a federal standard.
And this is one of the problems that you'll get to. There'll
This is
be
one of the
50
problems.
different, there'll be 50 different systems.
So one retort that I've heard often, Brother Smith, is that who are you to be the czar of health, right? So if I, as a legislator, have been elected by the people to represent their interest, I actually am the guy. I don't need subject matter expertise to make decisions for my community. I was elected to do that. And my job is to bring in subject matter experts who could do that. You know, the point to be made is that that is the type of retort or the argument that allows this type of states' right argument to advance. But it remains to be seen if and when that type of logic has ever improved healthcare outcomes. Just food for thought for people that actually want to follow that down the rabbit hole. And that's meant to be an objective conversation that could be challenged if anyone actually had data to support the opposite. Here's something that was weird to be found in the health section of the document, but there's a reason for it, and I'll get into it momentarily. Number 3 here, families comprised of a married mother, father, and their children are the foundation of a well-ordered nation and healthy society. The exact language that follows this assertion include programs under President Biden's Health and Human Service Department are fraught with agenda items focusing on LGBTQ plus equity, subsidizing single motherhood, disincentivizing work, and penalizing marriage. These policies should be repealed and replaced by policies that support the formation of stable, married, nuclear families. Obviously, when they say policies should be repealed and replaced, there are specific partner statutes that relate to provisions of healthcare that would be taken out in the effort to promote a very specific type of family structure. I don't know that that statement requires very much debate. Does anyone want to comment on it or clarify what you believe that means or what it represents if it were to be put into effect? We'll chalk that one up to a self-evident truth. Topic number 4, Medicare Part D reform. In other words, repeal of the Inflation Reduction Act. I will read this here. The Inflation Reduction Act created a drug price negotiation program in Medicare that replaced the existing private sector negotiations in Medicare Part D with government price controls for prescription drugs. These new government price controls will limit access to medications and reduce patient access to new medication. This negotiation program should be repealed, and reforms in Part D that will have meaningful impact for seniors should be pursued. And now, to the audience, it's important that what you're talking about in the public discussion is the set of actions that led to people of a certain income status and eligible for Medicaid to be able to get insulin for $35. And just on Thursday, 10 other drugs that treat conditions such as blood clots, diabetes, heart disease, heart failure, autoimmune diseases, and chronic kidney disease all were negotiated to a reduction of about 60% of the price at which they had currently been offered to consumers on a monthly basis. So that is the process that is being asserted should be repealed and replaced because somehow reducing prices is being thought to reduce patient access to medicines. Does anybody want to touch that or try to clarify that for the people listening?
Happy to do that. So the medicines that were announced today, Eliquis, Xarelto, are used for blood clots. I often have patients who struggle with the cost of these drugs. Giardiance is used for diabetes and heart failure and kidney disease. I had a patient this morning tell me that they can't afford that medicine, and can I give them something different? Januvia is a new diabetes medicine. Farxiga is used for diabetes and kidney disease and heart failure. Entresto is for heart failure. That same patient and another patient asked if I had a substitute for Entresto today. Enbrel is an immune medicine, immune modulating medicine that's used in rheumatoid arthritis, psoriasis. Again, huge cost. Stelara, a couple of the insulin pen preparations all fell into this category. So these are medicines that are very increasingly used. They're relatively new medicines. And what I always tell the patients, if you see it on TV, you know that the price is going to be high if they're advertising it. And that's what you're seeing. And I think that this type of a program actually has great interest by many of my senior patients, especially. And I think the concern is, well, if we negotiate the price, then drug companies won't make the medicines in the future. And my hospital negotiates the price that we buy the medications from. And every other hospital system negotiates price. All this said is that now the Centers for Medicare and Medicaid Services can also negotiate the price. So I think that these companies can still make money. I don't think that they're eliminating their profit margin. You're just not in shifting the cost burden to the seniors. And I think that this becomes increasingly important because all of the new medications are going to work on smaller and smaller and smaller numbers of patients. And so it's very costly to develop a new drug. But if you can spread that cost of the drug over tens of millions of people, then the price doesn't have to be so high. But increasingly, some of the medications, one of them that was announced, it treats blood cancers. So it's 17,000 Medicare enrollees that you're speaking of. So you're going to take the $1 billion it takes to bring a drug to market. Maybe that's too high, but you're going to spread that $1 billion cost over 17,000 people. That, by definition, creates a price structure that's very, very difficult to afford as a society. And every new medication that's coming in the future, it has targeted properties, and it will be available for smaller and smaller and smaller number of people. So this type of a strategy, I think, is going to be important as we look at price structures for the entirety of our pharmaceutical industry. So I think that this is important. The other things that are important of this is that while the proposal suggests eliminating the price negotiation, it also would eliminate a low-income subsidy program expansion, and it would also eliminate the cap on drug costs if you're in Medicare Part D. So I think that I think that those things are worrisome for medical professionals. And as a person who takes care of adults and seniors, I think that there are concerns around this point. I think that the idea of trying to protect drug development and innovation, I think, is a lofty goal. But I think that the way that this is being done, and this actually is only the first 10 drugs, I think that we're going to have to look at the others. But these 10 that were announced, I think my patients would find very, very popular. And I think that they would find, many of my patients would find very welcome.
Yeah, you made tons of excellent points, but I think we need to slow down and go over those last 2 points, because that's something that the consumers should know and know that they are going to feel. You specifically said that there is a cap that currently is about $3,500 a year on Medicare Part D out-of-pocket cost. That is due to come down to $2,000 in 2025. Under this plan, all of those considerations would be eliminated. So the cap wouldn't fall to 2,000. It wouldn't stay at 3,500. There wouldn't be a cap. So if you're on Medicare, specifically what this is saying is that in the interest of continuing, remember, we're supposed to be free market here. We're supposed to have competition, which is supposed to drive costs down themselves. So as long as you have multiple pharmaceutical companies in the market, you would think that they would be able to function at whatever the ROI needs to be to bring a drug to market. So that goes against that notion that capitalism will take care of this on its own. But to the consumers listening, you need to understand that your out-of-pocket costs are poised to not be capped and subsequently poised to go away. The second thing you mentioned was the low income subsidy program expansion, which offers $0 at no cost to Medicare recipients for drug plan premiums and for drug plan deductibles. So if that gets removed, you're going to be paying more because anything is more than zero. So let's just be clear on those points. Let's move on because this next topic is
actually one other quick point about
yes.
That. The other thing to remember is that this proposal would also make Medicare Advantage programs the default program rather than traditional Medicare Part A, Part B that would allow someone to choose the Part D pharmaceutical coverage. It would actually encourage, and the default when you're applying would actually be one of the Medicare Advantage plans.
And what's the difference between the two?
The Medicare Advantage plans are increasingly popular, and the number of persons who enroll in that, including my parents, have been increasing over the years because they roll the cost of the drugs into the program.
Mm-hmm.
But what's often difficult to understand for my family at the time you enroll is that then the managed program then decides what drugs, what services, what resources it wishes to cover, and those things are not immediately apparent to individuals at the health literacy that many in my family and my community have. And whereas Medicare Part A and B had a standard coverage that was uniform across the country, and Medicare Part D similarly. So any provider anywhere, everyone knew this is what when you bought Medicare Part A, Part B, Part D, this is what you get. When you get the managed care programs, the Advantage programs, they are very, very attractive because they give lower cost, but they give the lower cost because they cover less. And sometimes that's an appropriate choice for individuals, but it's not always apparent what the trade-offs are. And so making the default program has some risk.
Would you like to jump in? I know we shove time, Jeff, but I just have to say, like a broken record here, we've seen this rodeo before in psychiatry, and it hadn't really worked very well in mental health. Probably about 2 decades ago, we were flooded the market with a variety of so-called new generation atypical antipsychotic agents. They were great for people like me as young junior psychiatrists with some new options that could work better for patients, many of which had some better efficacy, but all pretty much had less adverse side effects that in the long run might make patients not take their medications. And some groups were at greater risk of being medication at higher risk. We clearly saw that when these price controls come into play, if you don't allow for the best medications to be available at prices people can afford, individuals will end up with no medication or the older medications that were cheaper and not as effective, either eliminating the acute symptoms or for us very often, keeping them out of the issue that's the most costly for a state or a government is long-term hospitalization. Same thing, although different medications. This is not an issue that works very, very well. Best healthcare occurs when the best medicine is available for the patients who need them the most at prices that they can afford.
And it begs the question, brothers Bailey and Narcisse, who's actually making these decisions as to what's included? Certainly it's not the consumer. You don't know if it's your individual physician, although it appears that it's not. So where's this advisory board coming from? Is it from the insurance industry itself, a government panel? These are things that are not clear. But the premise, if the premise is healthcare is best delivered by determinations between a patient and her or his physician, that seems to have been conveniently pushed to the side in this example. Is that right or wrong?
I think that's correct. I think that it's, again, the attractiveness of the top line price can really be seductive for many individuals. But if you say that the car costs $1,000 instead of $10,000, everybody's gonna flow to the $1,000 car. But the question is, what's in the $1,000 car? If the $1,000 car doesn't drive down the road, then $1,000 being cheaper than $10,000 may not necessarily be in the interest of the person who is looking for the transportation. So similarly, in healthcare, it's very difficult to compare apples to apples, oranges to oranges. And in my community, it's open enrollment season, and so you can't turn the television on without seeing ads for managed care plans. And some of the managed care plans are really doing an incredible job providing a service, but it's very difficult for many consumers to really comparison shop despite the services that are available. And the nuances are often a real challenge, particularly for seniors. I take care of a lot of patients with dementia, and so families and individuals under healthcare stress trying to make very, very sophisticated healthcare choice decisions is a real challenge in our community.
Okay. We're doing a good job of making these policy proclamations wonky, but there are some real issues that I hope that the audience is picking up on. And, that's a good segue to this next goal, reading number 5, Medicaid reform. Add work requirements and match Medicaid benefits to beneficiary needs. Here's some language from the document. CMS should allow states to ensure that Medicaid recipients have a stake in their personal health care and a say in decisions related to the Medicaid program. Personal responsibility and consumer choice for Medicaid recipients must go together as standing components of the safety net, especially for able-bodied recipients. Medicaid recipients, like the rest of Americans, should be given both the freedom to choose their health plans and the responsibility to contribute to their health care costs at a level that is appropriate to protect the taxpayer. Number 2, add work requirements and match Medicaid benefits to beneficiary needs. CMS should clarify that states have the ability to adopt work incentives for able-bodied individuals, similar to what is required in other welfare programs, and the ability to broaden the application of targeted premiums and cost sharing to higher income enrollees. Add targeted time limits or lifetime caps on benefits to disincentivize permanent dependence. Let me start before I throw it to you guys by pointing out, in case you aren't aware of the difference between Medicare and Medicaid, we aren't going to get into detail in that, but an easy way for you to have a general idea of what this discusses is that you care for the elderly and you aid the poor. So Medicaid is a program that predominantly serves the elderly population. Medicaid is a population that predominantly serves indigent individuals. So what we just read said that in the Medicaid population, where you're already talking about an indigent population, there are going to be efforts to ensure that if you are an able-bodied individual, that somehow you're being made to contribute to your own health care. I don't know what follows, whether you're guaranteed a job or some other way of being able to contribute, but that's the point being made. And similarly, there is a suggestion here that your benefits can be suspended either over an extended period of time of needing medical care or via a lifetime cap by which if you stayed indigent through no fault of your own or intentionally, I guess, that if you exceed a lifetime cap of care, whether it's through some catastrophic illness that you developed or trauma or otherwise, that a lifetime cap can literally prevent you from being able to access Medicaid. Have I overspoken, panel? Are there other things that you want to address in terms of this work requirement and matching Medicaid benefits to beneficiary needs?
Yeah, I'd like to. One of the issues that many states have run into when they use this kind of language is what exactly is the able-bodied? How do you define the person who has the disability? And I think as physicians, we could understand that this individual can't perform that type of work. But when the legislation is written around these points, it often uses very, very broad strokes and broad language. So then it provides a lot of room for interpretation. And I don't, if that interpretation is being done by states and regulators, I worry about that more than if it was done at the level of the physician. So I think that you run into a situation where a person who's born with a disability and may or may be able to graduate high school, but really can't enter the workforce, now has a lifetime limit to the amount of either time spent in the program or benefits received through the program. Well, some of these some of the kids that I take care of, I saw a person an adult who was born with a birth disability, cerebral palsy. I saw someone like that today, and he's 48, but that person can't work. And so I think that I worry that these types of languages and these types of programming would take a person who fits into this category, whose health may be good enough most of the time to walk and talk, to go shopping with individuals, but really can't function in society on their own and be a working member of society, a living on their own member of society. And I think that this type of language penalizes individuals like that and really puts them in a place where they end up in a destitute environment. And so I think we have to really work hard in thinking about work requirements. Work requirements did not serve many individuals in the cognitive impairment community, individuals with early onset Alzheimer's, individuals with mental health that I take care of that are admitted to the hospital frequently. Those kind of work requirements struggle in this type of a schema. Those individuals struggle in this kind of schema.
Well, I think we need to undergo a little bit of a history lesson here, because this is a paradigm shift. The able-bodied individual was never the metric by which a determination of eligibility for insurance existed. The reason, so we have to kind of question, isn't being indigent the metric of interest? That has always been the eligibility threshold for Medicaid. So that's the point here, is that I don't care if I'm able-bodied. If I am not able to afford these things, then that in and of itself precludes my ability to pay. And that's why Medicaid exists in the form in which it does. The second thing, and I know Brother Dr. Carter has some experience in this as well, historically, the reason why employer-based health insurance is a thing is an important part of this conversation. If the able-bodied individual is able to get a job, are you going to increase the burden on employers to mandatorily provide insurance to their employees and to extract funds to assist them for paying for that insurance? That's a question that has to be asked, because if you switch from indigent as the measure by which people get Medicaid to simply being able-bodied, you may actually be creating more problems than you're solving. Does anybody want to clarify that or address that in any other way?
Well, slightly different, but still on the point of the Medicaid reform. One of the other principles that this would do is provide dollars directly to beneficiaries, and that sounds like a really exciting idea of giving consumers choice by moving more of the dollars away from defined benefits to individuals who can choose what they wish. But again, the Medicaid programs historically have had looser minimum standards. And so one of the things that this would do is, yes, you can have, well, I'm going to give you the dollars to spend, but I'm only going to give you a certain number of dollars. And in the real world, the number of dollars that you have to spend really isn't sufficient for the services that you really need.
Yeah, I'm going to.
And
go ahead, brother.
Waiting for Dr. Carter, Dr. Smith, but a lot to say. I'm sorry. The reality is, this type consideration has historically, again, I'm a broken record, not worked well in the area of mental health. One reason we have exploding numbers of homelessness on many streets around urban areas in the U.S., including where I drive to LSU every day here in New Orleans, is that very often we don't provide a safety net for what we call a priority population of individuals who very often, whether they can work or not temporarily, can't maintain that for the so-called 10 years of work equivalent. They call it 40 quarters in the system of SSDI. Those individuals very often who are lost to follow-up and have these type of challenges. I'd agree with my good brother, Dr. Narciss. It's also true that this term able-bodied is a misnomer. The whole idea that you call it able-bodied makes me be afraid as a psychiatrist. Brother Narciss commented that he has mental health patients as well, that it's all too easy for many individuals to look at someone with their eyes, and if they don't see an overt problem, a broken leg, and they're on a cast, for example, they want to believe that nothing ever goes wrong with the brain. The brain can always function normally and optimally without impairment over a period of time. That's not been my experience in psychiatry. Brains, like other organs in the body, intermittently just don't work consistently and don't work well enough to obtain and maintain work. But that homelessness problem is what I'd be afraid of if you're in settings where you undermine the priority population and don't provide government-based assistance to keep those individuals receiving minimalized and satisfactory care and support in areas of need.
Yeah, thank you for that. I just want to put the people that are leaving comments on notice that we are going to be getting to your questions and comments. We have 3 more topics that we're going to get into, and I'm going to take the next 2 together because they are grouped together. Reissue a stronger transgender national coverage determination. Exact language here. CMS should repromulgate its 2016 decision that CMS could not issue a national coverage determination regarding gender reassignment surgery for Medicaid beneficiaries. In doing so, CMS should acknowledge the growing body of evidence that such interventions are dangerous and acknowledge that there is insufficient scientific evidence to support such coverage in state plans. All of that means to say eliminate coverage for transgender operations. I'm going to continue on in another section titled Radical Redefinition of Sex. On August 4th, 2022, Health and Human Services published a proposed rule entitled Non-Discrimination in Health Programs and Activities. This rule addresses non-discrimination provisions of the Affordable Care Act, which is enforced by the Office for Civil Rights and the Centers for Medicare and Medicaid Services. This section prohibits discrimination on the basis of race, color, national origin, age, disability, and sex in covered health programs or activities. Here's some exact language for your consideration. Under the proposed rule, sex is redefined. Discrimination on the basis of sex includes, but is not limited to, discrimination on the basis of sex stereotypes, sex characteristics, including intersex traits, pregnancy or related conditions, sexual orientations, and gender identity. In other words, the department proposes to interpret this section as if it created special privileges for new classes of people defined in ways that are highly ideological and unscientific. The redefinition of sex to cover gender identity and sexual orientation, and pregnancy to cover abortion should be reversed in all HHS and CMS programs, as was done under the Trump administration. This includes the Children's Health Insurance Program, also known as CHIP. Low-income families who rely on CHIP should not be coerced, pressured, or otherwise encouraged to embrace this ideologically motivated sexualization of their children. I'm going to stop there. That's actually a plain language repudiation of any non-binary sexual orientation or identification, and the call to enact policies to repudiate any inclination to do so. Does anyone want to clarify that, take issue with that, or speak to that? Has what's been read sufficiently addressed the challenge? Brother Bailey, I know this is, once again, you can say what you've been saying here.
Right. Well, I wanted to defer to my brother colleagues here, and I can understand this is a challenge in many areas. But as brief as I can state it, issues regarding gender, sexuality, sexual reassignment are hugely difficult for all the persons I've ever seen in my entire career. Often they are met with a remarkable strife and internal conflict, psychologically and emotionally. Often they are met with differential misunderstanding and at times overt antagonism. I have to say, at times vitriol by people even who are close to them, sometimes family and friends close by, and other times the person who don't really know them or don't know them well or in their circle, I think, of influence. So I've taken a position as a professional that these individuals who need more, not less, help and assistance and care and understanding because of the difficulties that I think these challenges bring to them. I think at times attempts to legislate these issues imply a frank misunderstanding, in my professional opinion, of how much difficulty many of these individuals are having dealing with these challenges. This seems to be, unfortunately, on the same line of thinking.
And I'm seeing in the comments that these comments that I read were pretty easy to interpret and are considered self-evident as to the ramifications to those members of the population who identify in the non-binary ways that were being discussed. Last point before we open it up for comments and questions. COVID-19 vaccination and mask requirements. Just going to read some of the legislative actions that are being proposed here. Announced non-enforcement of the Biden administration's COVID-19 vaccination mandates on Medicaid and Medicare hospitals. If you're not familiar with what those are, we can discuss. Revoke corresponding guidance and regulations. Refrain from imposing general COVID-19 mask mandates on healthcare facilities or personnel. Pay damages to all medical professionals who were dismissed directly because of the CMS vaccine mandate. For those of you that aren't aware, there are several hospitals in which the employees were neither inclined to mask for their own protection or to mask in the event that they would be carriers and could infect patients who otherwise weren't infected. The challenge here is whether or not that is a right that, whether the right that exists there is the right of the individual to not protect themselves, or if the right is greater to protect patients who come to that facility previously unharmed. The document language here clearly would reverse the inclination to protect patients from healthcare workers who may be infected in favor of allowing healthcare workers their rights to exercise their freedoms to not be protected as had been recommended. Anybody want to comment on that? We all spend a sufficient number of time in healthcare settings, so let me toss it to the panel.
Yeah, I work in the first hospital system in the country to require vaccine mandates. And as a result, a number of individuals who declined to do that sued the hospital and lost in federal court. So I think that the idea of who gets to decide these things, should it be politicians or should it be health professionals, is really central to the issues. The language of Project 2025, for example, would require or would restrict the ability of the Department of Health and Human Services of declaring a public health emergency, and would require that if such a declaration was made, it then had to notify Congress within 48 hours, who would then decide the scope of the declaration, the duration of the declaration, and whatever actions would be taken. And so I think that that's a very clunky system. I don't think that any of us would think that Congress could do very much in any 48-hour period of time, as it's currently put together. But the idea that the scientists, the healthcare providers, are the ones who make the decisions around vaccination mandates, as opposed to politicians, I think is the central issue.
I'll comment on that. So I think if we start from that piece of legislation, from public health preparedness around a pandemic, by limiting, basically this project would limit some of the infrastructure that allows us to be able to respond and track outbreaks globally. So monkeypox, for example, bird flu. You pick your virus, and also secondary to that, it would actually, so first of all, we'd have a delay, and then we would have a delayed response in any type of development of vaccines or preparing vaccines. It would also then undermine vaccine confidence within the population. So if you think about, then a consequence of that would then be potential increased risk of healthcare shortages. The entire public health infrastructure and healthcare infrastructure, we could actually see an increase in amount of worker shortage. Obviously, many people left the healthcare field during the pandemic, and we continue to see the consequences and division among healthcare staff. That could even be exacerbated. Okay, and then what's the consequence, the impact? It always comes back to the vulnerable populations, the folks that basically are at greater risk, elderly, immunocompromised, chronic conditions. Kind of back to your point, Doctor's brother, Surgeon General Sterling, is that, again, increased risk of deaths. I think what you saw during the pandemic, where we're able to put all of these things in place, we knew the pandemic was coming. We had the infrastructure, laboratory infrastructure, the laboratory network. We got ahead, the investments that we made in vaccines. We had robust workers. We implemented mask mandates to protect healthcare workers. While we had 1 million deaths, it was significantly less than we could have had. I think what you would see is tens of millions of deaths with some of these policies implemented, because each phase of that allowed us the ability to respond effectively will be compromised significantly by this policy.
Thank you. We're going to be wrapping up now, and we have no more than 10 minutes that we're going to do. I wanted to extend the courtesy of responding to some of the comments here. There's two in particular that I'd like to get at. And this is an interesting question. I'm going to paraphrase the question. What would prevent states from restricting vasectomies in an effort to protect the unborn in the same way that abortions are being restricted, theoretically, potentially restricted?
I think it opens the door for that, to restrict vasectomies, just the same as they're somewhere down the line right now. It's being discussed about contraceptives and the control of contraceptives. So basically, when we talk about vasectomies in that same vein, yes, it opens the door for that particular action down the road.
Any concurring or dissenting opinions? Okay. Next question here. Are all insulin medications the same? I'm thinking about your comment on comparing, requiring nuance. I think what Brother Phillips is getting at here is what's being proposed here protecting insurance companies' ability to produce newer medicines as much as it actually is driving people toward the acquisition of generic medications, because that's pretty much all you'll be able to afford with the cost controls being removed?
I think it's reasonable. There are insulins that are short acting, there are insulins that are long acting, there are insulins that are mixed. And there are sort of older preparations that have a different cost structure than the newer ones. With the cost controls that were put in place, the idea was that all of them would be $35, but there are opportunities for individuals or for companies to use an insulin delivery system, much like you think about an EpiPen. I think everyone remembers the story of the EpiPen. The epinephrine that's in the vial is very, very inexpensive, but the delivery system is the thing that was costly. And so I think that we need to be very, very mindful of those as we're going forward. So that this type of nuance is something that doesn't often get written into legislation. And I think that it takes a very sophisticated conversation around how to develop the best structures for this. And I don't know that that fits into a TV commercial. I know it doesn't fit on a bumper sticker or on a baseball cap. So I think that when I talk to my parents about these things and about the choices, they don't always make the choices that I would recommend because they're looking at things in a very, very broad way instead of a very, very nuanced one.
Let me give each of you gentlemen, should you choose to take advantage of it, a minute to give any thoughts or advice or comments to the public. And again, thank you for participating in this very delicate discussion. So let me just go around the horn here. I'll start with you, Dr. Bailey.
Briefly, I thank you as well, Brother Sterling. I think your comments and your leadership throughout the course of the year or two have been outstanding, really leading up to, I think, today's discussion. In summary, I'll say four things very, very directly. That healthcare, I think, in my opinion, functions best as a right for all people, matters, I think, in our society. And what about thinking through these considerations in that fashion, might one really think about the high-level risks that may occur when we work to differentiate what level of access to care one's going to receive. A huge issue in mental health for the last couple of decades, issues regarding access and whether individuals can receive the care that the data would argue empirically is best for them. I think a second issue that's also important is I think the general gist of today's discussion has been pretty clear, and I agree with my colleagues on the panel today. These are issues that are remarkably difficult and so almost frankly impossible to optimally legislate because, as you said, I think very articulately, the nuances that very often create various imbalance and differential concerns that particularly individuals come in with. A physician that's trained, I think, over a career is best apt to make optimal decisions or give advice to the individuals based on very often differential, if not competing concerns. Very difficult to legislate with a one-size-fits-all approach, as I think some of the considerations today incur. Third, I think I made the point, and I'll end with it. Mental health has always been a huge challenge in our society because of stigma and adversity and mistreatment of persons with brain illness versus other forms of illness in our society. Many, including maybe legislators, I don't think really fully grasp the risk they put patients at, and that's patients' livelihood and their mortality, not just whether somebody's odd or different and will be in some other place. But you talked about homelessness earlier. These are remarkably important issues for whether someone can live and live life abundantly and fairly and safely. We as psychiatrists always speak up in every venue on the behalf of the mentally ill. That's what I've tried to do today. Thanks for having me.
Outstanding. You're up next, Brother Dr. Carter.
Yes, I'll reiterate. Thanks again for your leadership and really, bringing us collectively to help inform our community on topics that actually matter. And so this particular one, we've heard a lot of sound bites, but I think, really focusing on the facts and having some conversation about what is stated and what's the potential risk, to the populations. And many of us either work or live or come from these vulnerable populations that could be affected. And so for us to come together collectively to evaluate as professionals with the expertise any types of reform, regardless of who is putting it forward, and having that conversation is most important. So just really want to thank you for really the leadership and wisdom and ability to actually get us together to talk about this as it pertains to public safety, public health, and protecting families and really access to care and what it really means to our overall population from a healthcare outcome, access to care. And so I just want to thank you again for that and a great conversation that we had tonight.
Thank you, good brother. Dr. Narcisse.
Yes. Thank you so much. We appreciate your leadership. This is a very difficult topic, and it speaks to the challenges of our society when it comes to delivering healthcare that works for everyone, because it is such a nuanced topic. The federal government has never been widely recognized for its nimbleness, but having a federal healthcare set of standards did provide a basic minimum of care that everyone in the country would get. The types of proposals that are here speak to changes to Health and Human Services, to the CDC, to NIH, and on a certain level, the ideas of trying to make them more nimble and more responsive sound very, very good. But I think that when one delves deeper and deeper and deeper into the means by which this is done, it creates an environment where minimum safeguards throughout our healthcare system are reduced or eliminated in favor of more competition. And the competition works when you are cognitively sharp, when you have time to devote a significant amount of effort to looking at the nuances of this program versus that program. If you're the person who can trade individual stocks, these kinds of things sound really, really good. But for many of the patients, many of the people who receive these kinds of the benefits of these kinds of programs, the types of paradigm changes are problematic. And I worry especially for those who are seniors, who are cognitively impaired, those who are indigent, those who are poor, those who are at the margins of our society, that as a physician, I swore to protect. And so I think that we really need to engage in this kind of conversation and really understand where we can make improvements, but still provide minimum benefits, minimum standards. And I think that that's the heart of the case here.
Outstanding. Thank you. And Brother Dr. Smith.
All right. Thank you, Brother Sterling. And I want to thank you for your leadership. And I agree with the other panelists, the fellow deputies here. And I really want to thank them for their comments on this very, very challenging topic. And as we look at this proposal that we have been discussing, there are excellent topics there. They are valid topics, but we have to delve deeper into these topics and look at the what and the why. And as Brother Narcisse was just saying, we have to get into the details to see what the ulterior motives are here. One of the things that I would like to say as we close is that healthcare itself is a major determinant. Good health is a major determinant of the quality of life. And when we say that we agree to do no harm and to help our patients, then that is what we are all about and what the genesis of this whole discussion is about. So I would say to the audience, be very cognizant and reading and discussing this document, delve down to see what the issues are and look at who's stirring the pot. How many people are stirring the pot? Because the more folks we have stirring the pot, the worse the stew is going to be. And I guess my last comment is to be mindful of your oral health, your dental health, because after all, your dental health is a component of your overall health. And so let's be mindful of that, of oral disease, and make sure we take good care of ourselves. So thank you very much.
Outstanding. Thank you, gentlemen. You're all outstanding in many regards, and I greatly, deeply appreciate and love you as brothers. To the audience, we have tried to present just the facts this evening. Some of these, if you are politically aligned a certain way, may appear to be flavored one way or the other, but they really are self-evident truths that we've been discussing. There are choices to be made. If any of you are inclined to review any summaries or to look at the document, I would caution you to appreciate the difference between the comments that are being made in the introductory statements and the legislative proposals. It's literally beautiful that what Brother Dr. Smith said. These are topics that really warrant discussion and consideration. We didn't get together this evening to demonize a political party or religious ideology. We wanted to deeply and seriously consider the thoughts that are being made here And although the topics that are being raised are valid and worthy of consideration, there are some legitimate concerns that can be expressed in how those concerns will manifest and translate into what are being suggested as legislative proposals. We're literally talking about eliminating major components of the Affordable Care Act, to cutting Medicaid benefits, to increasing Medicare Part D prescription drug prices, eliminating reproductive freedoms nationwide. We're talking about cutting back on medical care for those who can least afford it, increasing prescription drug costs, and leaving more people than currently have health insurance without coverage. We're talking about repealing the Inflation Reduction Act that allows the government to fix prices on behalf of people who cannot afford the full prices of medicine, like insulin. That $35 consideration is a real thing for people. So just think about it. I actually enjoyed the debate. Just full disclosure, I've written policy proposals for Republicans as well as Democrats to try to clarify the ideology and have that translated into policy. I very much would love to engage the deputies again if there was a Democratic proposal that was comprehensive enough and forward reaching into the next term to discuss the pros and cons of that. But this is work for you to do. You need to be an informed consumer, not only of your health, but of the proposals that translate into your votes, that translates into the quality of your life that will be forthcoming. I greatly appreciate Alpha Phi Alpha Fraternity for giving us this platform to have this type of conversation. Again, our goal was not to be political today, but to inform. We will continue this conversation in subsequent events, and thank you for your time. Good evening. God bless. Talk to you again in a few weeks.